like we're having technical difficulties, so all the funny jokes that I just made got missed. But basically something about Seth being young, Alex being a little bit older, and Daniel being rude. I don't know if that holds up, but we'll start off from there. Episode 20.
Yeah.
Been gone for a couple years, and now we're back with Seth, resident doc. Should I give everybody nicknames like Fat Joe? Give me a nickname.
No, Bird.
Alex now doc. Daniel, you know who I am. If you don't, stop watching and I don't know, get your life together. So you're gonna go over case first. Got 2 cases, commentary, and
Peanut gallery.
weigh in. Yeah.
Peanut gallery.
We just had some Wahlburgers. They're gonna be sponsoring the show soon. That's what I heard.
Yeah. Talked to
Thanks,
Mark the
Mark.
other day.
What's the brother? It's not Donnie. Does anyone even know his
Is
name?
it Rob?
Rob Wahlburger?
He's the famous chef. You really should know his name.
Like how famous are we talking?
I mean, I watched the show.
Like he works at Hardee's, but he like
I mean, if it's
No,
the
you don't know
easy
who he
man, I
is.
probably don't know.
He's renowned.
yeah, renowned. You know, 2 case.
All right. So, 29.
Paul.
It's Paul.
Paul. Okay. Sorry, Paul. 29-year-old male golfer presents with right-sided abdominal pain that began about a week before I saw him after doing some long drives. He used to compete in, like, I don't know what you call it, when they try to drive as far as you can.
Long drive.
Long drive. I thought they had like a name.
If you can tell, he didn't play sports growing up.
Not those sports. All right. Later in the history, he tells me the same day that he also helped his buddy lift his boat out of the water, and that's kind of when he also started feeling the abdominal pain. Wonders if he had some sort of hernia.
I mean, being an astute clinician, did you ask him what kind of boat? We're talking a yacht or a John boat?
No,
We're talking jet ski.
probably like canoe. No, he's a big dude.
That's probably not matter.
Yeah.
Whatever. We keep going.
Anyway, the pain in the side of his abdomen is like, it's just described as dull and tight, and it was pretty intense whenever it happened, and had gotten better since I when I saw him what happened. Movement doesn't necessarily make it worse, but he like stopped all his physical activity because he was like, I don't want to make anything worse, and not be able to play golf. Because he was getting ready to play, like he plays a ton in the summer. He also has prior medical history of varicocele in his abdomen that were removed 15 years ago, and the pain that he's feeling right now is like right around where one of the minor scars was. So like literally every case I've ever heard you talk about with scars is in my head, like they do with the spleen and all that.
The guy with the spleen.
Well, actually, I guess he doesn't have a spleen anymore.
I get a part of it.
Not part of it. Okay.
You got a spleen?
I guess I've never seen it.
You just have a guy with a spleen?
So then he also was recently diagnosed with, he had some spermatoceles that they're going to be surgically removed. So I don't know. That was where I was originally thinking like, oh, this might be more involved with that kind of thing. Like,
Did you check cream steric reflex?
Yeah.
Why don't you check that with everybody?
I thought you were going to provide the answer you were saying.
But I just asked if you had a spleen. What do you want? I want you to talk about the case.
Okay. So that's like all I've got for the subjective. Exam findings, top tier SFMA, dysfunctional non-painful cervical extension, multi-segmental flexion, and then functional painful right rotation. Everything else was functional non-painful. Neuro was within normal limits, range of motion, limited non-painful, like I said, cervical extension, T-spine extension, and lumbar flexion, and then limited hip ER and external extension bilaterally.
You had said that he was a long driver.
Yes,
Was he right-handed or left-handed?
he's right.
Okay. Did he have pain when he was swinging a golf club?
Well, he hadn't. Also, it happened when he played, like when he was doing long drives, and then he hadn't played since. Like he'd done nothing in that week. Orthos, there weren't really any that were positive. Like his straight leg raise was limited bilaterally. And then on palpation, when I did skin rolling over the right side TL junction, that reproduced his right abdominal pain. And then I also like pressed on, which we later looked it up, iliocostalis thoracis, and pressed on that, and it referred to the abdomen as well. So that was like pain audit, the skin rolling, and then
What was the pain on it?
skin rolling. And then functional audit. Now, I'm actually meaning to ask you this. Do you put functional audit in trigger point? Or do you put trigger point in functional audit or pain audit?
No, it has to be functional.
Right. So that's, I've got that, and then the hip extension bilaterally, and then the ability for him to flex his lumbar spine, because he can touch his toes, never mind, that was dysfunctional, not painful. Can't touch his toes, but also like super flat lumbar spine.
That couldn't be a functional under anyways though.
Why?
Too many moving parts, man. Passive range of motion, trigger points, joint restriction. That's all you got.
Okay. Well, can it be lumbar flexion, joint restriction?
Yeah, but that's not touching his toes.
Well, no, I wasn't saying the touching his toes. No, like just.
I'm curious on the pain on it. Why'd you choose the skin rolling versus right rotation, which is functional and painful?
I thought I couldn't have top tier.
Pain on it, you can. There's pain.
Okay.
I'm just curious. I'm not saying you're wrong.
Yeah.
I'll tell you if you're wrong.
No, oh, he will.
So then my differential at the time was mains, or I don't really know how I would say like the trigger point is causing the pain, like succinctly.
We're behind closed doors. We can say that ICD-10s are bullshit.
Okay.
Yeah.
Then we can open the doors back up.
Yeah.
Yeah. Yeah. The doors are actually
99.06. Yeah.
Yeah. Lower extremity. Okay, and then so the interventions that first visit, we did some lumbar flexion, supine and seated, cupped over TL junction, and then quadruped rock backs, and then worked through breathing and DNS first position or child's pose. Just trying to put him in a flexed position and then breathe behind it.
Did you adjust the low back?
First visit, no.
Any reason why not?
That was typically done on the first visit.
Why not? It doesn't cause cancer.
Yeah.
Just curious.
So that all like his pain wasn't gone on the pain audits, but they were better. And then his hip extension got better, and well, like I guess the trigger point was functional audit, but I don't remember which one I sent him home with. I think it was just the breathing and it was breathing inflections. I sent him home with it. Yeah.
Where'd you say his pain was originally?
Right, like anterolateral abdominal wall. And I did look, and he had scars over those areas, but it was like really small. And so we didn't do any like mobilizing over the scars or anything. I guess maybe if that hadn't worked, I would have done
What are you saying that worked?
like working on the breathing and flexing his lumbar spine. Anything else before visit two?
How'd you rule out visceral? Like, was anything in his history warranted to that? Did you like any kind of gallbladder test or anything like that?
Gallbladder test.
Push on it.
Yeah, we pushed on.
Rebound sign? Fun stuff?
No, I didn't rebound tenderness.
He's probably dead now. Yeah, it's okay. It's okay, people. We'll check in on
Just you wait.
Yeah.
Normally, so we're trying to pick a case, and Seth and I are talking about it, and he goes, you don't have to pick a case that you like failed on, or like, I don't know. That's just what I feel like people want to hear.
So what in like the main
This is almost
innervation?
successful.
In the mains innervation, do you think like what nerve?
Or you were saying calling it mains,
Yeah.
but like,
Just peripheral nerve entrapment in
yeah,
general.
like,
Yeah.
or the trigger
Because
point
none of those are
referral.
going to go farther down.
Yeah.
But
Yeah, or they wouldn't wrap that far around.
right, but I guess then again, not the succinct way, but he dumps into TL extension when he's playing golf, probably, and so that's
So maybe the same mechanism, different presentation.
yeah.
Compressive intercostal nerve wrap around maybe. basically the first thing I thought I'd just base off location
Mm-hmm.
in case you wanted to try some yapping around there.
And like on this spot, or are you saying on the back?
This one.
Yeah.
Because if it's intercostals, then I'm not really gonna go after intercostals.
Which I guess I would have said it was probably below rib cage, but I guess that could still.
T12 subclass.
Some yeah. Okay, second visit, he was like significantly better after the first visit, and played 2 rounds of golf in the last week. Didn't have any issues while he was playing golf. And then, as far as like the skin rolling it, didn't have any pain with that. The trigger point in the costalis was it didn't radiate anymore, so it was like still kind of tender but didn't radiate. And then hip extension better, still limited. That day we did did some breathing in 3-month supine and a door frame squat. Again, just trying to get him to flex through his lumbar spine. And then we needled the trigger point. And yeah. And I don't know that I actually changed anything at all. I might have sent them with the door frame squat.
Mm-hmm.
That was pretty much it for visit 2.
How many times have you seen him?
4.
Okay.
Visit 3. He played golf 3 times in the last week. Didn't notice any tightness in his back or his abdomen until like the 3rd round. He also had his longest drive in competition to date, which was 406 yards.
All you. He sucks. You're great.
Yeah. No, I think if you saw this guy, you'd be like, yeah, you'd probably smack a golf ball.
Didn't he play baseball at Auburn?
Yeah, he played baseball at Auburn. And then the left hip, no longer limited in extension. The right one still was better, still wasn't up to snuff like with the left. And then I don't really think the hip external rotation had changed much. Skin rolling, no pain. Interventions that day were 6-month to 3-month supine transition, and then we started working on the 6-month prone, controlling his lumbar spine in the quadruped position and moving his arms and legs around it. So, anything else? No? Last visit,
We're just waiting until then to tear this to pieces.
Okay, so he crushed 4 drives over 400 yards in the however many rounds he played that week. I don't remember.
This is just like playing golf. This is
Yeah, just playing golf.
I don't like this guy.
Yeah.
Taking a pitching wedge in from par 5.
Yeah.
It's crazy.
The only like this visit he had mentioned some stuff with like some periscapular pain, so we worked on that, and that pretty much went away with cervical retractions. But I want to say his range of motion from the audits of like hip extension, hip external rotation were about the same on this visit as well. And so we worked into like tripod, and then I don't even know what you call them, but the kneeling, inline, rotational.
Yeah, we said.
No, like when you're going more after, I guess for most people I usually use it for balance.
Hiatus?
No.
Jump?
Inline rotation.
When you're kneeling and you're there, inline
Chops?
rotation.
Inline balance.
Yeah.
Cable chops almost.
We could guess and we're gonna make up a name for it.
Inline vestibular visual
Choppies.
chop.
Choppies. Well, because I was trying to put him in a position where his hip would be extended, and then also start working on rotation, and trying to make sure that he's not like extending through his low back while he's doing all that. So yeah, and that's kind of where we're at with the case.
Yeah.
What's your end goal with him?
Mm-hmm.
So like, he probably doesn't very often like pull his own skin.
Yeah.
What's his like goal that you're trying to get him to with doing the 6-month variation, the end line? Like,
Yeah, I mean, I think the things I've been trying to change the most as far as the functional stuff is the hip extension and the ability for him not to dump into lumbar extension.
for what purpose?
So that when he's playing golf, he doesn't have future problems.
Perfect.
Yeah. because he plays a lot.
If you love pain science, make sure you email Dr. Alex Coleman. Anatomical lesson of pain. I'm sure somebody will scream at us, and let him scream because it's only falling on deaf ears that don't know anything. What are you gonna have him work on, like in a gym setting, besides like 6 month plank? You get all that stuff. Like, is there anything you're like, hey, I suggest you like start working on this?
Yeah. I guess that's kind of where we were headed with last time, where we were trying to split. I was
Like
doing
split
split
stance
stance,
stuff, yeah.
you could split squat or reverse lunge, and you could do something with rotation involved with that as well.
Mm-hmm.
Do you ever do any deadlift variations? Since you have,
I haven't,
get some rounded or get some
yeah.
flexion.
Yeah, like that one. Yeah. Yeah, I like that. I don't know how much he like works out
Outside
of golf, but
If you did, you probably landed on the green. So I mean, at least he has a challenge now. Because
Yeah.
he hit it twice before it gets on the green.
yeah.
So it's very easy. I'm just waiting for his gallbladder to explode.
Yeah. Yeah.
The golf
Review19 is nice time.
I wouldn't say it's that normal.
No, yeah, that's what I was originally.
How'd you, what was oblique, like strain? I mean, baseball, golf, was that ever, where it is?
I didn't think about that, but
Maybe you have pain, like, on movement, like, from supine or anything, or rotation, resist rotation?
he did on rotate. Yeah, the right rotation. Top tier.
Just, top tier.
That's
Is
it.
that gone?
Yeah, it's gone.
Is anything else changed top tier? Because that was functional painful.
Yeah, the only other two were the cervical spine extension and multi-segmental flexion.
Is that still the same? I'm assuming flexion's still the same.
Yeah, I mean it's better than it was.
Mm-hmm.
I mean, it's not. I also, I've heard you ask people the question, and I ask them too. But as far as like, have you ever been able to touch your toes?
Mm-hmm.
29. I don't know. I don't think he's one that could ever touch his toes before.
Mm-hmm.
But I guess, to what degree do you feel like, that like we can get you to touch your toes?
Greg Rose and Greg Cook may argue like a primary pattern would be flexion, right? Think like fetal position, and then for a golfer, they have to, load extension, load flexion, and impact, get back out. And then they say like, instead of not options, right? You're going after, hey, access hip extension and not going to low back extension. They may say instead of coaching the non-low back extension, give them access to flexion.
Mm-hmm.
So instead of having to coach something, you just give them access and you kind of let it go. I don't know. I'm just saying, like, so then you could go like even like SFMA style, like working on, unloaded flexion, resisted, all that stuff, and just kind of, which you kind of are, and that's kind of what Seth was saying, is deadlifts too.
Yeah.
That might be an option where you're not like trying to stabilize, you're just access flexion, in both directions work from.
Mm-hmm.
Just the deadlift at the top would kind of mimic like the bottoming out of like the golf swing, if that makes sense. Because if you're trying to give him access to some flexion, when he comes through for impact, like the bottom part wrist appraise is like a deadlift position, and then coming out of it.
One of what I've found over the years because when we went through the SMA stuff, you use a lot of like the assisted flexion and all that stuff. Lumbar spine flexion is hard to change, right? So I think first, you work on motor control. Then there's probably like, things, tissue that's changed over time. But once you've done that, I think you have to motor control flexion back in, and that's sometimes a lot harder than you think. So that's like, the 4x4 matrix is remove parts of gravity, right? So you're trying to get somebody on the floor assisted. That's where like those lumbar spine like pulls, like you're climbing a rope sometimes. Even something like a 3 month to 6 month, like you're trying to work on pull into flexion. I think it's just one of the harder things to change overall because it's such a dominating force of a rotational athlete to get stuck in extension. But, just an option or an add-on. You can still just go that way with all the stuff you're working on.
Yeah, thanks.
So what was the reason why he had to have his spleen removed in the first place? Did you say he had his spleen removed?
That was a dirty guy.
Yeah, that was my guy.
Yeah, I know.
I really like.
He had the varicocele.
My guy was like T1 knife fight scar.
Where Alex, he was the guy with the spleen.
Yeah.
What's his last name?
Most guys don't have a spleen.
He wears shirts, he has hair.
He was that one guy that looked at us.
Right? Solid. Good.
Yep. Baton.
There you go. So actually, I'm glad I got an update on this case literally like 2 hours ago, so it kind of helps this. But this is a friend of ours' daughter, so it's a little bit easier to work around the information because we just are getting constant feedback. But about 4 months ago, maybe more, a desk. Well, first of all, back up. This is a high-level soccer player, 13 years old, girl, probably doing too much volume of work, in particular going through growth spurts. She's grown a tremendous amount in the past year. And about 4 or 5 months ago, I had a desk fall on the dorsum of her left foot at school, and they thought there was fracture. Actually, Daniel is the one that ordered image on her foot, right? Just rule it out, no fracture. But again, if you have trauma like that, it's pretty significant. And then continues to play soccer. Well, on the back end of that, a couple weeks later, I saw her in here on like a Saturday or something for Achilles pain on that side, and she was getting ready for a showcase. So we do fly-by treatment for that because she's leaving or they're getting ready to leave. I don't see her again for that because, again, friends and family, it's sometimes not ideal just because they don't follow the treatment plan. So then we start hearing via text and things that she's having foot pain that's not going away. I just assumed it was Achilles stuff still going on. Well, then I get a call one day that, hey, we took her to an ortho because she's still having foot pain, and they're wanting to do a gastroc resection, like a partial resection on her lateral gastroc because her Achilles are so tight because she's growing. And I was just like, no. Point blank, no. And then the dad tried to explain to me what they were thinking. Like, my question was, is she having Achilles pain? He goes, no, the pain's on the top of her foot. I was like, well, you have to explain to me really, emphatically how Achilles tightness, gastroc tightness is affecting the dorsum of your foot. So by the time they come in, they've seen, this ortho specialist. She's not playing soccer for that week because she went to the ortho. Now they're kind of scared. Also, that ortho thought she needed to rule out like tarsal coalition just based on exam. Don't know if she's got kind of a pes cavus soccer player person's growing foot, but like if anybody knows how to palpate, obviously not that ortho, would know not to check for that, but it was in her note. So we have the note. The interesting thing on the ortho's note had no, and again, maybe she asked them to put it in there, but that's rare because somebody is writing their notes as they go. Nothing noting the desk falling on her foot. Talking about where the pain was now, they get an MRI and it shows edema over what she just labeled as TTL, basically the mid-tarsal joints. Doesn't say anything else, and then talks about the gastroc resection. So it's literally saying edema on the top of the foot, pain around the dorsum of the foot, and then she comes to me and we kind of talk about, well, when she comes to me, her pain is like just posterior to the lateral malleolus. And then literally she traces like her peroneus longus tendon around there and then says it's kind of just medial to the ATFL if you're going to point to that. And then the very first thing I do is we're starting to go through exam, and I'll go through the exam proper, is just push on peroneus longus, and it referred right into the trace mark around her lateral malleolus, and push on peroneus tertius and radiated right into the dorsum of her foot. And I was like, So we go through an exam, make sure I didn't miss anything, and the subjective, all that was there. General presentation, she has a grade 2 bunion bilaterally, and this is a 13-year-old. She's been soccer cleats. We've actually worked with her on stuff like that before. And again, we've had a lot of touches, so it makes the case easier because you kind of know what you're doing. Daniel's worked with them on performance stuff. But when a kid's having that much change, right, deforming where their first stray is and going through a growth spurt and has trauma, get ready for whatever pain wants to present, however. Top tier, functional on all of them. Like no pain. So very good mover. As she goes through gait, she has toe in with excessive supination on that left side. So she's like swinging this left foot in. Lack of toe off though, so she still exit over the fifth metatarsal, which you have no clue if that's pain or was that there before. And then upon exam, as far as range of motion, decreased ankle dorsiflexion bilateral, which we had to address very quickly because that's what they were being told the surgery is going to be about, and like resection. So we go in, they're the exact same bilateral. Now they're a little stiff bilateral, I'd say maybe 10 degrees, maybe with knee extended. She gains probably 15 degrees knee bend. So we know that gastroc is wound up. She's growing a lot, that's normal. Exact same bilateral, so we just kind of are trying to explain that. All the neuro was normal. get into palpation. You know, she traced where her pain was. I've already palpated trigger points. She was tender to touch over the posterior to lateral malleolus and over ATFL, like I said, and then trigger points in peroneus longus and tertius. Beyond that, nothing else. I mean, you know, all orthos and everything were pretty normal, except when she resisted eversion, and then when we took her through passive inversion, she still had pain over that kind of posterior lateral malleolus area. So all of this to me in the beginning is just barking like, you had trauma, you changed what you were doing, and now you're overloading like the lateral aspect of your foot, like from a soft tissue standpoint. Well, then we have her, you know, do some functional testing, like just, hey, let's look at some things that, you know, what causes pain. Toe walking elicits more pain than just walking, which both of those are a little painful. And then single leg and double leg jumps. Double leg jumps kind of hurt, single leg jump on the left side hurts worse. So those become, for me, like could have been the pain audit. I mean, you could use tenderness to touch, but I'm using single leg because that's the one that she's like, man, that's the worst. Mm-hmm. So my functional audit is purely that peroneus longus trigger point, right? As referral, it's right where pain is. I was pretty confident. I'm telling Mom, hey, I think we can get this to go away. We'll see if the pain changes. My treatment focus to do that is foot intrinsic stability motor control, right? I think the way she's decided to use her foot, whether that was prior to trauma or after, I have no clue, it doesn't matter. Then obviously integrating that up the chain as we get further into it. So, you know, my kind of thought process at this point is, like I said, like you're having a mild tendinopathy of trigger points, and it's hard to determine honestly which one is causing more, because there's no swelling, there's no, you know, swelling. She never had signs of bruising around the lateral aspect of the ankle. So treatment wise, I go after, you know, we adjust her midfoot on that left side. She, like I said, she on palpation, mid-tarsal joints. She doesn't have great pronation through the mid-tarsal joints. I don't do any, I think I did a little stecco over kind of peroneus group on that side, and then went immediately into DNS. I'm just hanging, left-sided hanging with like little heel raises, and literally after we did that, go back, trigger point was like shrunk. So you'll see like an active trigger point go, you know, from the massive area down to like the middle of the belly, goes down, and like we literally couldn't reproduce her pain. And then like she jumps and she's like, it's much less. And that was like 10 minutes, 15 minutes. Mm-hmm. And then I was like, okay, we can't send you home with hanging. So the homework on that first visit was, we tried two things. We had to land on the squeeze and lift. So you got your feet parallel, you're doing calf raises, squeezing, trying to use both sides, like posterior tibialis and peroneus longus together like reins. Tried to do that because when she did single leg, where she's pushing with the other foot, like too much pain. She's like, that, can't do that. And then beyond that, we sent her home with, what was the other thing? Triplanar, like ankle and calf stretches, both like ankle moves, calf stretches, like Gary Gray. She comes back second visit, she's doing much better. Now she's not playing soccer. We said, hey, we're gonna approach this because she's had past injury history of just, like I said, like injury, a little bit of treatment, go, and it's just cycle. So the fact that now we're talking about the surgery, they've had an MRI, her parents agreed. I was like, we're gonna have strict return to play criteria, which I told her first visit was going to be pogo jumps on that leg. Mm-hmm. Then you need to be able to do a double and single leg decel jump off like a 12 to 20 inch box. Then you'd be able to do that and cut. Like you do that and you don't have any pain, I feel pretty confident you'll go back out. So they're on board. Second visit she comes in, very similar to the first visit. Trigger points, you know, referral, not that bad. Start working on the same stuff. I don't think we changed that much, but I did start putting her in a bear position. Because again, when she loads in bear, just like when she walks, she wants to splay out onto the lateral digits, gets away from her big toe. So I started working on that in here, and I was like, hey, you're still gonna go home with squeeze and lift. If that's not painful, start working on single leg squeeze and lift, triplanars all day long. The exact same stuff. Hanging, adjust her foot, all that. She comes in a third visit, and you know, what's my pain audit? Single leg pogo jumps. She pogo jumps, or I always have her do double leg, gauge that, single leg. And she's like, man, it kind of hurts over here. And she's pointing to like, you know, middle of her ankle, even, you know, kind of medial part of her ankle. Like, man, that's weird. Like, you know, lateral and then ATFL and then medial. So I always find myself telling patients like, well, if pain's moving around, that's neurologic, right? It's not tissue. Mm-hmm. My other thought though was she may have some osteochondral lesion because she's like, you know, cuffing her ankle like this. So I'm like, dude, I got to rule out, but one more spine. So this is me being an idiot. or just something I didn't think would be apparent at all. No complaints of low back pain. She's fairly young, so the history isn't, there's not a massive history of all these different injuries. So first thing I do was
She was also a gymnast that she knew.
Was a gymnast, yeah, prior history, but I asked her mom, did she ever have any low back complaints during that? No. So I went after extension first, just based on, she's a kid, some mild restriction there. As we're doing just extension at first, non-overpressure, she's like, kind of feels compressed. Overpressure, she's like, that hurts. I was like, well, let's just see what happens. So I do that. We do 20 reps. She gets up. She says better. And I was like, So we go back, adjust her, then overpressure. Then it gets worse. Instantaneously, I'm like, spawn blow. Like, okay, that's, if you're taking instability, like you can do one thing, it changes it. So then based on that, I go into a slump test because I was like, well, I should have done that first. I have never seen a more severe case of neural tension in a slump test in my life. So first of all, she had pain, in particular with cervical flexion at right, I don't know, L2, L3 almost, pretty high. And then when you right leg's normal, left leg, which is the symptom side, you extend her knee, she would get radiating pain, didn't come from her back, it was just over the lateral part of her thigh or right above her knee. And then her, foot would stay plantar for like 15 degrees, and that was a hard stop. Hitting this desk. I was like, oh man, missed this.
She also had pain on the left, stork test positive on the right.
Yeah, but remember it was kind of weird because it was like she had pain on the right, stork left, nothing right. Because usually it would trade, you'd still have pain on the left, on the right. And thanks. So I wouldn't say I'm confused, but I'm like, man, pain on extension. The extension though was changing the neural tension, but her symptoms would get worse. So then we sent her home after that visit with flexion. I was like, you got to go crazy for 2 days, just flex. We had her do, someone calls it roly-polies, rock and roll, and then just seated flexions or lying flexions. She comes back and she's like, it's no better, maybe a little bit worse. And again, she's not playing soccer, so her worst was we had her doing bear crawls at this point, up and down her driveway. And she's like, that hurt. Trying to jump rope, that hurt. I was like, so then we go back after it, and we're just getting more specific, really going after this slump test. So what do we start doing? Exploring, lateral deviations and things like that, because she has right-sided back pain, left-sided symptoms. Work on contralateral neurodynamics, no change. Then we take her through right hip slides, right lateral hip slides. She goes back down, neural tension's gone. Things are, she has very little dorsal flexion to start with. Now she's back to 0 in a seated slump, still at back pain though, and still has this radiating pain, lateral thigh.
And that's right-sided lateral?
Yeah, shift her to the right.
Why didn't you go left?
So before that, it's a good question. We did static openers. So did a static opener on the right side or left side down, right side open. Did both sides. When she was on her right side down, left side up, she was having back pain. So closing it down, it didn't improve the slump test. Switch sides, improved slumps. Then we did, standing hip slides, and then it kept getting better. Interesting thing with her is we got her back pain to go away. We literally had to load flexion to create back pain. But then her ankle pain, she was like, I think it's the same or getting worse. But the neural tension was completely gone. So then I was like, but still thinking spondylo, because like we said, we did a little bit of dead bug stuff. It was like, if she has a not awesome stability strategy or decide to lock something down and we get it moving, right? Who knows what's going to happen symptom wise, but then we can still offload the neural tension because she just may have some sort of nerve root specific stuff. So the cool thing about this case is cool. Took me 3 visits, but it was a presentation, same presentation, her ankle each time. Gets a little bit better, it kind of stalemates, different presentation. Now we're like, okay, explore something else. Her mom sent me a text because I sent her out of here. I was like, okay, we need to kind of start testing this. Sent her home, I was like, hey, you're just doing lateral slides. That's it, right? In particular, if you have pain. So she goes out and I said, you can dribble the ball around, run a little bit, see if you're any worse. So that she had no pain whatsoever, running around and dribbling for 15, 20 minutes, but then gets done, it gets terrible, worst pain she's had. Yeah, in her lateral ankle. Does 15 of those hip slides, completely abolishes it. So, not saying we're 100% on it, but we're moving a lot closer. But Seth and I were talking about this before we got on here. She's probably just going to be a pure stability play around because we're talking TL junction, pretty high. So we'll have a follow up on a future episode. But I mean, that was one where it's just like, you got a lot of stuff going on. She's also, the parents at least aren't pushing really hard now. Usually they would be, like how soon. But there was a little bit of that last week, like, well, when can we start doing stuff? Because we've been 2.5 weeks with nothing. So now that's my goal, is get her back to running around a little bit, dribbling, no like big shots. But who's to say there's not a spondylo, just not awesome, like TL junction movement, growing kid, it's really irritated. But I told her mom, we talked about it. If she responds poorly, right, continues to have pain, and neural tensions bounce around, you gotta get imaged. Because then you gotta rule out like stable, unstable, is something actually there. Yeah. That would 100% be an MRI with a kid versus just a oblique series or something like that. Yeah, so like I said, you already know what the extended plan is, because that would be like the return to play criteria I said. Yeah, that's 4 visits in. So 4 visits plus the feedback today, and then we'll see her again Monday or Tuesday and see what's going on. So yeah, and then they're gonna leave for like 2 weeks over the 4th. So that'll be gotta get her going by then. What do you guys got on that one? Trying to see if I missed anything.
I was just thinking how many times like they've called, and for either one near you to see her just in the last year for random ankle stuff, that you're kind of like, okay. And then try to go elsewhere, originally get treated, thought that it was, but that was only because we weren't playing, because that was over the winter. And then you're back, and then, because like when we did some performance stuff last year, we even did like what they were supposed to do before every practice and game, like was actually a nerve slider of both branches, and now I'm like, I know for sure we weren't doing that.
No, it's just interesting that he said like there may even be more history than like they're letting on of like the desk and then the Achilles and like that's what's hard with this, like, you can't go back and be like, oh yeah, it started again. Like again, she just could overload TL junction because she's slightly stiff in upper T-spine, and it's not mains, but it's just like you're driving into a hard extension right below like L2, L3. So I don't know, it'd be interesting to see how she presents. Because I wasn't putting her in that category. I was like, she would come in, 13-year-old girl, but like, how are you doing? I think it's worse. She said that on the second visit, comes in, no pain on palpation around her ankle, almost no pain jumping. I was like, you're better. She thought it was worse. So there's also that part of it too now, because she's had pain for so long. I think it's not gonna be tough, but you're gonna have to do hard stuff and show her you don't have pain before she gets back into soccer.
Yeah, I think it's another one of those that you just have to continue to go back to making sure that you're ruling everything out of the case, right? Like you palpate a trigger point and you reproduce the exact same pain, but who's to say that's a trigger point versus just the peripheral nerve that's innervated from coming out of the back?
Also, you have trigger points because you have central sensitivity.
Yeah, so she's just like trying to, like she's not loading or stabilizing well on her back, like she's just trying to overload so much down the chain till
make up for it.
I think the overlooked piece of that was the moment in the second visit when you made the decision that the pain location